Greetings to friends and colleagues across the globe. My name is Dr. Mark Smolinski, and I am president of Ending Pandemics, a not-for-profit organization located in San Francisco, California, that works in low and middle-income countries to find and respond to outbreaks faster. At Ending Pandemics, we take 5 priority actions to transform disease surveillance. The first of these is directly engaging the public, and this we refer to as participatory surveillance, which will be the focus of this presentation today. Our second priority action is to deploy a One Health approach. As 3 out of 4 emerging infectious diseases directly spread from animals to humans, it is important to apply a One Health approach in all efforts at finding and responding to outbreaks faster. Our third priority action is to expand epidemic intelligence. And through our work in this area, we are helping build One Health dashboards that bring animal, human, and environmental data together within ministries of health, agriculture, and the environment to help them understand, analyze, and eventually predict and prevent outbreaks faster. We are also expanding epidemic intelligence through our network of volunteer epidemiologists across the globe in a program called Epihacks. Epihacks now has over 3,000 members in 154 countries that are helping verify potential outbreaks faster, generally in less than 24 hours. Our fourth priority action is to help countries build networks regionally so that any outbreak that would happen in a particular area of the world can have the cooperation with neighboring countries to stop that outbreak faster should it spread beyond national borders. And lastly, but perhaps most important, is to help measure progress. We have developed a set of timeliness metrics that are 11 measures to help countries continuously monitor their performance in predicting, preventing, responding, and controlling diseases across the One Health spectrum. But again, today is about participatory surveillance. And I would like to begin this presentation with a 2-minute video that highlights what exactly we mean by participatory surveillance and showcases some of the programs we have helped support across the globe. With that, we will roll the video.
Outbreaks happen every day around the world. The challenge is preventing any one of them from becoming the next pandemic. Speed matters to stop a spark from becoming a raging fire. We need eyes and ears everywhere to quickly identify and report unusual events in humans, animals, and the environment. This approach is called participatory surveillance. Communities are actively stepping up to become part of the solution. In Cambodia, people are reporting health events in real time through a free national hotline. In Thailand and Tanzania, local health workers are finding outbreaks in animals before any spread to humans. And in Brazil, this approach was used for the first time during mass gatherings. Everyone has a role to play in stopping a threat anywhere from becoming a threat everywhere. Expanding participatory surveillance across the globe will keep us all safe from the next yet unknown threat. Help us empower all communities to stop pandemics before they start.
I hope you enjoyed that brief overview of some of the systems of participatory surveillance that exist across the globe. At Ending Pandemics, we define participatory surveillance as the bidirectional receiving and transmitting of data for action through direct engagement of target populations. You may hear many terms out there, such as citizen science or community-based systems. What's important is the bidirectional component, that we're not only receiving information from a particular group of persons, but also providing useful information for action to help respond to any threat that is identified through such a system. It's also important for participatory surveillance to be contributing to official disease surveillance within a country and not necessarily a research or pilot project that does not help inform and improve direct action to emerging threats in any particular place where such a system is operating. We'll now move to share with you more details on 5 systems that have been developed in Cambodia, Thailand, Tanzania, South Africa, and Brazil. In each of these systems, we will have a short video presentation followed by a Q&A on each of those systems with the key developers or operators of those systems. This portion of the presentation is an encore presentation from bringing each of those 5 systems together from across the globe for the Skull World Forum this year. And we recorded that session and now would like to share with you that particular portion that includes each of these short videos in detail and the Q&A of each of the systems with myself and those key persons who are connected with them. At the conclusion of this brief encore presentation, I will come back with some concluding remarks, and at any time you can email questions to us regarding any of the systems you're about to receive more information on, and we'll be happy to follow up with you with each of those responses. So with that, sit back and enjoy this quick trip around the world and seeing what kind of innovation is helping to find and respond to outbreaks faster.
បាទថ្ងៃហ្នឹងខ្ញុំបានឡើងពីដំណេកខ្ញុំក៏បានដាក់ចំណីដល់មន់ជ្រូកពេលនោះខ្ញុំក៏បានប្រទះឃើញមន់របស់ខ្ញុំហ្នឹងពីរក្បាលងាប់ផុសផ្លែកពីធម្មតាគឺវាមានច្រាលឈាមពណ៌ខ្មៅនៅលើក្បាលលើសេវាក៏កប់ជួនខ្ញុំក៏បាននាំកូនទៅមណ្ឌលសុខភាពដើម្បីបើកថ្នាំខ្ញុំក៏បានឃើញអត្តប័ណ្ណផ្សព្វផ្សាយអំពីជំងឺផ្ដាសាយផ្សៃហើយពេទ្យក៏បានប្រាប់ខ្ញុំថាអាចទេទៅបានពេលនោះខ្ញុំបានត្រឡប់មកផ្ទះវិញក៏ខលទៅ115
គោលបំណងសំខាន់នៃគម្រោង115នោះគឺដើម្បីរកឃើញទាន់ពេលវេលានៃជំងឺរាតត្បាតនិងឆ្លើយតបទាន់ពេលវេលា
យើងទទួលបានសារពីនាយកដ្ឋានប្រយុទ្ធនឹងជំងឺឆ្លងតាមរយៈលេខទូរស័ព្ទ Hotline 115 ទទួលបានព័ត៌មាននេះភ្លាមក្រុមឆ្លើយតបបន្ទាន់របស់ថ្នាក់ខេត្តជាមួយនឹងថ្នាក់ស្រុកនិងបុគ្គលិកមណ្ឌលសុខភាពបានចុះទៅពិនិត្យព្រឹត្តិការណ៍នេះនៅភូមិបាយ៉ា
ថ្ងៃក្រោយបើសិនជាឃើញមន់ងាប់ច្រើនអញ្ចឹងខ្ញុំនឹងខលទៅលេខ 115 បើសិនជាគេចុះមកសម្លាប់មន់ខ្ញុំទាំងអស់ក៏មិនអីដែរព្រោះជីវិតមនុស្សសំខាន់ជាង
Welcome, Chane. It's good to see you. We've obviously partnered together for over a decade with the Southeast Asia iLab in Phnom Penh, which it's so great to have you as the leader of that organization. And for those of you who don't know the iLab, Chane and her team are local developers who really help in service of governments and the private sector in Cambodia and neighboring countries in Southeast Asia. So welcome, Chane. We've seen many successful projects and products come out of the iLab in Cambodia, including this national hotline in partnership with the Ministry of Health. So what key lessons do you want to share with our virtual audience about the national hotline that was developed in 2016?
Thank you, Mark. Uh, so 115, when it was established in 2016, it was co-designed closely with the Ministry of Health in Cambodia. It was actually the idea of the 115 were actually coming out from the first Epihack in Cambodia by the School Global Threat Fund at that time before turned to ending pandemic. Yeah, so the key in here is like the goal was the hotline was to detect the outbreak signal in the community. That was the goal when we're setting up with the Ministry of Health at that time. And we did not anticipate to come across something like COVID at this time. It was originally like we're looking at like H5N1 and in general the detection of the outbreak in the community. And with the preparedness in advance and of this hotline, and when COVID hit, it was immediately Cambodia was already prepared itself. So the hotline has served in a full strength of supporting the public during the COVID. Yeah.
Excellent. And can you help the audience understand how this national hotline is accessible and free to everyone in Cambodia?
Yes, thank you, Mark. So the hotline was designed based on the interactive voice response, and it's accessible by all the population in Cambodia by even with the basic phone. They don't need to have a smartphone. And the hotline is a toll-free line, and it's work with all the mobile operator in Cambodia. So basically, anywhere that have the mobile coverage in Cambodia is accessible in this whole language. Importantly, so that means that even those like illiterate people that cannot read and write, as long as they can speak, they can talk, they can participate in the text, the outbreak signal, in reporting the cases, and so on. Yeah.
Yeah, I remember the challenge at the event of the Epihack, which I'll mention in a moment, but it really was the direction from the ministry for, at that time, the 14 million people who lived in Cambodia to all be able to access that. It was exciting to see the various schools, including the voice command for, simple phones, and especially with the large literacy rate in Cambodia, it didn't matter. People could still interact and leave messages and so forth. So I know that hotline had been operating for several years and receiving up to 600 phone calls a day, and 20 to 30 of those were often human or animal health issues that were being reported. This form of participatory surveillance that really, is one of the few that is nationwide and getting a lot of information, especially my understanding is that it's scaled, to 18,000 calls a day during COVID. But has it helped bring the human and the animal sectors together and looking at, information from both risks coming through a single device? And can you speak to maybe the power of this data to really also bring sectors together?
Indeed, Mark. So with the information that the community reporting, for example, like we're talking about zoonotic disease, like we have the case like in 2017, where the farmer report about the abnormality, like the video presenting in the death of their chicken. So basically, the community participating, the information, the data reporting from the community, it encouraged more of the both human and animal have to pay attention and look closely and work together to respond to that. Because this is not just a report from the officer, it's a report from the voice from the community.
Yeah, excellent. Well, thank you, Chane. You heard the magical music, which is telling us our time has come to an end, but thank you very much. And with that, you've talked about breaking down silos, and now we can move next door to an overview video of the system in Thailand that's taking a One Health approach, uniting both human and animal surveillance by design. So let's roll that video, please.
แต่ก็ไม่เคยคิดนะคะเพราะอายุปูมีแล้วใช่ไหมพอมีโครงการนี้ขึ้นมาสอนให้ป้าได้รู้จักคำว่าสมาร์ทโฟนก็เป็นการที่น่าภูมิใจ
PODD in Thai means look closely and you will see.
It's similar to Chrome and Instagram without any filters that help the volunteers in the village to submit abnormal health events in real time. It's really important to empower regular citizens to become a disease detective because it is the only way to scale up the surveillance capacity in the global scale. Engaging everyone with a right tool and with a right incentives can solve any problem.
Great. Well, welcome Toy and Jack from Chiang Mai University, Faculty of Veterinary Medicine.
Hi, Mark.
Good to see both of you. Jack, I still can't believe that we first met almost 10 years ago when you were merely a student and
Yes.
faculty. And Toy, it's been great to see how your career has advanced alongside the PAWDD tool. So thank you both at this late hour for joining us to share some further insight. So the PAWDD pilot was in 2014, and it really is exciting to see that it's providing evidence that participatory surveillance, may be one of the most cost-effective and efficient ways to save lives and livelihoods by orders of magnitude. And it's really great to see that the system is helping us understand that. So let me just first start with Toy, because this tool, we understand, really is being used by volunteers like the grandmother that we saw in the video, who it was wonderful to meet a few years ago. Can you help us understand the challenges of training volunteers in the village and how you overcame those challenges?
Okay, thank you, Mark. Okay, back to 2014 when the PAWDD project started in Chiang Mai, Thailand. At that time, most of the smartphone users were teenagers or young adults, while majority of the PAWDD volunteers were like seniors or elderly people with the educational level of under bachelor degree. So it is one of the challenge. One of the challenge was accessibility to smartphone, internet, and technology that was limited in the rural area in Thailand. So we decided the PAWDD application to be flexible and to be friendly to use. It comes with the online and offline function and the data input by letting the volunteers to focus on only one thing at a time on their screen. And during the training, we found that the young girls help and encourage the elders whenever they struggle with the technology, as well as the monitoring and evaluation were needed. And we also learned that multiple level approach and communication were important to harmonize the community working. And yes.
Yeah, no, that's terrific. And I know there's so much pride among the volunteers when you get to meet them in person, and it's really exciting to see. So on the other end, the volunteers are helping, to look for zoonotic diseases, since we know 3 out of 4 diseases jump from animals to humans. But Jack, we often hear, skeptics of participatory surveillance say that, why would there be an incentive to report if in the end it just means you're going to come and kill off all my chickens or my livestock? Are you finding that's true of the farmers in Thailand, or how have you managed that potential risk of this kind of tool in the community?
Oh, yes, of course. It's many problems when we implement the PODD. Not only large-scale culling that we face, but also the conflict within the community and livestock authorities. At the early stage of PODD implementation, the livestock authority, especially in the district area, did not agree with PODD, and they didn't want to use the PODD application in their area. They were afraid that PODD was the burden. Before the implementation, they tried to control the outbreak by themselves. If they cannot control, they will report to the higher level or their chief. But once PODD was used or was implemented, every level knows together immediately after volunteer reported. District authorities need to take an action. They cannot cover the outbreak within their area and try to solve the problem at that time by themselves. While in the community, many volunteers don't want to report the case if it occurred in their neighbor house. When the officer come to those neighbors' house and the neighbors didn't realize what happened, they will doubt the volunteer near them first, that the volunteer reported. So the volunteer don't want to be suspicious. Of course, we overcome those barriers by including district authorities to be a part of PODD team and find a process to help their work not to be their burden. And for community, we encourage the whole community manipulate by themselves. When the officers come to the community, they need to contact with the leaders of community first and then work together. Moreover, PODD team had to keep privacy of data and volunteers so that authorized people can access the data. That's that we work.
What is one key, exciting, unexpected outcome or one key lesson in 20 seconds or less that you've learned from PODD? Toy?
Yes, okay. Mark, one thing that I found during I work in the PODD, as Jake said, one of the unexpected impact was the volunteers report interference from the some authorities. As Jake said, in some cases, the authority don't want the volunteer to report via the PODD application due to it will be documented, or it could be a cause of the community panic, or the notification will send to their chef. So the authorities, some of the authorities interfered and asked the volunteer to avoid using the PODD application in relevant events such as the forest fire or the abnormal sick and dead animals, and so on.
Yeah.
So I think that to cope with this issue, the understanding and the communication among the stakeholders, especially for the government agency, are very important.
All right, well, thank you both. You heard Chane mention an Epihack. The PODD tool was also created through an Epihack, which is a process that we created at Ending Pandemics that brings both human and animal epidemiologists together. for a week with partners from the government and academic centers and local developers, and as much of private sector partners as we can bring in as well, to really co-develop tools that are then used to find and respond to outbreaks faster. And we often bring a participant from a future Epihack to a current Epihack so that they can see one being done in another country before they host one. And this next video is the outcome of an Epihack in Arusha, the host of which were participants at the Epihack in Chiang Mai. Please roll the video.
If we needed any reminding, the Ebola virus epidemic in West Africa and the ongoing COVID-19 pandemic have emphasized that national and global health security hinge on our ability to detect disease early at source. Zoologically, that is potentially zoonotic diseases in animals before infection of people, and geographically, that is at community level. As Africa bears probably the highest burden of infectious diseases against the background of a limited resource base, it is important that our strategy for early detection to trigger early response be One Health and community-based. The SACIDS Foundation for One Health has pioneered Afya Data as an open-source digital disease surveillance tool that eases the collection, analysis, documentation, and feedback of public and animal health events from community to national level, targeting public and animal health and the environment. Afya Data allows trained community members in remote areas to transmit health information to local surveillance systems. Information is then verified through testing and then acted upon. The tool can be customized based on different clients' needs, including language, surveillance, and data integration needs.
For the first time, I introduced Afya Data to our district. It's very important because we use it to inform other people about different diseases, which are mostly notifiable disease from animal to the human being. For example, anthrax, tuberculosis, TB.
Early detection at community level leads to national and global health security.
Great. Well, welcome, Ezra. You've been instrumental in many tools that we've worked together on in the region, but this is exciting to see where Afya Data has come. And so maybe we'll jump right in, and now that people have seen the video, I'm sure they're curious why you chose first to work with the Maasai community. So explain the relevance of that group as sort of your first target population and how it fits into, you know, your overall vision for One Health.
Thank you very much, Mark S. Actually, we chose to work with the Maasai community because of their actually where they live with the animals, both livestock and the wild animals. We started working in Ngorongoro, which is a unique ecosystem cohabited by the Maasai from the human side, and also their domestic animal, but also interacting with wild animals without an offense. So for us, because SACIDS is One Health, has One Health focus, that is actually a relevant entry point, because when you enter through animal, the passionate, the Maasai have the animal, you can also identify the public health issues.
Yeah, fantastic. And I know that this tool has really changed health-seeking behavior in Tanzania and various communities that you've worked about. So can you help us understand more about how this tool really is leading to different health-seeking behaviors as a result?
Yes, the Afya Data and the design of participatory surveillance actually allowed us to introduce this cadre, which operates between community and the official system. We call them the community health reporters. And this is equivalent to community health workers in public health, but us, because the same person identifies and also reports the event from both human and domestic and wild animals. So we designated them the community health reporters. So with actually, because these are the unique people selected within the community, they're known to the community. So by virtue of having them from the community, then they are trusted, and therefore with time, actually, when people are used to the after data community health reporters, they become very trustful of the community health reporters, the tool, therefore reporting more events. And also we have the referral system where the community health reporter connects the event identified in the community to the official system, therefore making the referral system very important and trusted by the people who would otherwise not be willing to report to the normal official system.
Great. No, thank you so much. And just one quick question back to you, Ezran. How has the AFIA data or the participatory surveillance improved timeliness in disease reporting or response?
Yeah, absolutely. It is. I mean, we have some examples both in humans and animals where events that would have otherwise been missed captured through the system. First of all, the participatory surveillance is linked to the district level reporting system, which reports to the national authority, and also the veterinary side. And therefore, this application of AFIA data has proved to improve the timeliness in reporting events in both human and animal health sectors.
Great.
Yeah.
Thank you. So moving from Tanzania to their neighbor next door to the south, we're excited to share an example of participatory surveillance being incorporated into the Health Connect tool in South Africa. Please roll that video.
Hi, my name is Gustav Preikelt, and I'm from preikelt.org, a technology nonprofit working in South Africa to improve health. I'd like to talk to you about Health Alert. It's a system that we developed together with the Department of Health in South Africa to combat the spread of COVID-19 during the pandemic. In March 2020, we were in a very unique situation in South Africa, knowing that we had almost 100% mobile penetration, and also having worked with the department in developing Mom Connect, which now reached more than 1 million people via mobile devices. We realized there was an opportunity to communicate and set up a system to rapidly disseminate the information that government felt every person should need in order to respond to the pandemic. In a few short weeks, less than 2, we collated information with the department and were able to launch a WhatsApp-based informational service supplemented with USSD and SMS. We had a national campaign on television, and during the lockdown announcement from the president, were able to get millions of people to sign up to get personalized information and to be able to ask questions of the system as well. Our goals were threefold. Firstly, we wanted to make sure that we had a trusted, secure, and real-time information portal that could be updated on a daily basis. Secondly, we wanted to build a self-diagnosis tool so people could test their symptoms to know whether or not to get tested, especially during the early days, to not overburden our physical health infrastructure. Finally, we wanted to take that information and be able to upload that to our national data infrastructure to be able to build predictive models for our Department of Health, to enable them to predict the future spread of the disease. The system had unprecedented success in terms of a national rollout. More than 10 million people have now access to the system, which is almost 25% of our population. On top of that, we've sent almost 500 million messages in the 5 national languages of South Africa. We also believe during the rollout of the vaccine, we now have a system that we can communicate on an individual basis with every single person that's communicated to us in the past. And in future, we believe that this will be the bedrock and the foundation of a truly inclusive national health communication platform. Thank you.
Well, welcome, Gustav. Please, over to you.
Thanks. I think we've kind of been inspired by this idea of using consumer technology to connect, to go directly to the patient and to support them not just only in the technology that they already have, but also in the kind of modalities that they're used to interacting, and always supporting them directly and offering the kind of information in real time in a way that they're used to connecting with each other, to connect with their friends and their loved ones. And so when on the technology side, we chose to work with consumer, what does everybody use? A mobile phone, and specifically chat and WhatsApp. So we used WhatsApp to build a bot to communicate with a really large number of people really quickly. But I think the key is that we provide it in a way that they were very comfortable in doing it. And it goes to show that now not only do we have a bot, but we have an opt-in rate of more than 60%. We reached 25% of South African adults, almost 50% of households in a couple of months. But technology is only one part of it. The other one is obviously you can't get to the scale without, and I think a lot of people here have said that, without government support. And we were really lucky that we already had a partnership through the Mom Connect program that we ran with the Department of Health that we've been running for the last couple of years. And then that we could work together in we literally built the system in 2 weeks, getting all the information, getting it on a WhatsApp platform, and then having the endorsement from the Minister of Health, from the President, really promoting this national hotline everywhere to get, I think we had within the first weekend a couple of million users on the platform already. And I think that was really the key, is to have that endorsement. I shouldn't forget, obviously, the carriers as well, the network operators promoting that number, and being able to combine that idea of consumer technology direct to the patients with this deep endorsement was really key, I think.
Great, terrific. So thank you, Gustav, for that overview. Our final guest speaker from Brazil, because I would be remiss in not talking about an effort where, quite frankly, was something we hadn't expected when we first started working on participatory surveillance. And this was a request that came from the Ministry of Health in Brazil saying, have you ever used this technology for a mass gathering? And they were contacting us in February of 2016, and they had in mind the World Cup that summer. And so, as you can tell from the other systems that you've heard about, that we've worked with partners on the ground, the key is to have local talent combined with the government buy-in. And so we were fortunate enough to meet Onicio, who was just starting up Epihacks at that time. And they not only helped with the World Cup, but again, it was used during the Olympics 2 years later. And the tool itself is being used by various partners within Brazil. But Onicio, in starting off the Q&A, I'm going to ask you a question that probably lots of people have in their minds right now as they've heard about these various systems, and you've been involved in one or two yourself. How do you see this approach of participatory surveillance really being applied to the pandemic or to future pandemics, or something that, like, in the big bird's eye view, help the audience understand this approach and, how it's being used or where it could be used, or just your thoughts considering we're all sitting in a pandemic right now?
Hi, Mark. Thanks. So it was very important in Brazil. We started participatory surveillance back in 2014 or 2016 because that helped a lot during the beginning of COVID pandemic, when the pandemic started hitting Brazil. Several health secretaries there were aware about the benefits of participatory surveillance, and many of them adopted that in order to have this tool helping fight the pandemic. More specifically, there is a really important case that I'd like to mention. In a city in the northeast part of Brazil, the health secretary was trying to optimize the coronavirus tests in order to make them more efficient, since there was a partial limitation of distribution of it. And they accepted to combine data from participatory surveillance and from traditional health surveillance, enabling an innovative approach for identification of clusters of risk areas. Within those risk areas, they were able to prepare test trucks going at communities and deploying the task in people from that risk areas previously identified. And this strategy increased in more than 88% the capacity of identification, helping them to make non-pharmaceuticals interventions at community level.
Great. Oh, thank you for sharing that. It's a great example. I hope you enjoyed that encore presentation and learning in more detail about several systems across the globe that represent simple technologies such as a national hotline, the use of this approach for mass gatherings, and also how participatory surveillance design for the early detection of disease threats has expanded, such as the system in Thailand, to cover many other things, such as reporting on the counterfeit sale of drugs in villages, to landslides and natural disasters, to monitoring for food safety and water quality. We're also happy to share with you that since that encore presentation, the PAW-DD system in Thailand was awarded the grand prize in the Trinity Challenge out of 340 programs from 61 countries. And we're very proud of our partners at Chiang Mai University and at Open Dream Development Company in Thailand for creating such a unique and terrific example of how this approach is saving lives and preserving livelihoods. We'd like to share with you now our plans to host the International Workshop on Participatory Surveillance, hopefully as an in-person meeting in the fall of 2022, currently slated to be held in Phnom Penh, Cambodia. At this meeting, we want to bring together not only the partners we have supported on participatory surveillance, but other systems that we are identifying in other countries across the globe, as well as partners who are interested in learning more about this approach and implementing it in the countries where they're located. The meeting will establish participatory surveillance as a standard of practice and help identify standards for data collection, sharing, and other methods of bringing this approach to the forefront of how we detect and respond to outbreaks faster in all hotspots for disease emergence in all parts of the world. We will also be expanding this approach to look at how wearable technologies and other advances in technologies are contributing to the self-reported systems on participatory surveillance, and looking at how artificial intelligence and other machine learning are turning these systems into the ability to help predict and prevent diseases as we move forward into this next phase of a post-COVID reality for emerging infectious disease detection and response. We hope if you're interested in learning more about participatory surveillance that you'll join us at this workshop, as well as visit our website, endingpandemics.org, and click on the tab at the top for IWOPS to not only learn more information, but if you know of a system, we have created a forum for you to share that with us, as we are creating a global map of all participatory surveillances across the globe that include those that have been designed for human health, animal health, and environmental health. And we'd love to hear from you directly on any system you may know about, as well as to sign up to become a participant at the 4th International Workshop on Participatory Surveillance. With that, I thank you for your time and attention, and we look forward to receiving any emails from those who want more information, have questions or comments, and want to engage with us on this exciting new frontier of bringing participatory surveillance to all areas of the globe and essentially putting the public into public health. Thank you very much.